This 1900s dental clinic is a workspace built for surgery. For over a century, the standard of care followed a concept called extension for prevention, where practitioners used heavy machinery to cut away large portions of the tooth to prevent the spread of decay. Notice the practitioner operating the drill in this image. This mechanical approach required the permanent removal of healthy enamel and dentin. Once a tooth was cut, it entered a lifelong restorative cycle, often requiring larger and more invasive fillings as those original restorations eventually failed. Today, the understanding of dental caries has moved beyond the idea of a simple hole in a tooth. It is recognized as a biofilm-mediated, sugar-driven, multifactorial dynamic disease, an active biochemical infection driven by the bacteria living on the tooth surface. The profession realized that mechanical repair cannot cure a biochemical infection. You cannot drill away a poor diet or a high bacterial load, forcing a shift toward minimally invasive dentistry, which focuses on managing the disease itself rather than just the damage it leaves behind. To understand this medical model, we have to look at the core biological mechanism driving modern dentistry, the demineralization and remineralization cycle. This microscopic cross-section shows the demineralization phase. When bacteria ferment dietary carbohydrates, they produce lactic acid, causing the local pH to drop below 5.5. At this acidity, calcium and phosphate ions dissolve from the tooth's carbonated hydroxyapatite structure. In the remineralization phase, saliva washes over the tooth, buffering the acid back to neutral, allowing the ions to rebuild the crystal structure. To align with this biological reality, the Australian Dental Council established new professional competencies. These standards mandate that every newly qualified practitioner adopts a preventive biological approach to care. The disease only progresses when the acidic withdrawals of minerals exceed the salivary deposits. Managing this microscopic balance is now the modern practitioner's primary clinical responsibility. This document outlines the Australian Dental Council's competency framework. Under Domain 6, Person-Centered Care, newly qualified practitioners are held accountable for recognizing health as it relates to the individual, prioritizing preventive management over purely surgical responses. Competencies 6.1 and 6.2 require practitioners to perform rigorous clinical information gathering and management planning. Before treatment begins, a clinician must identify the root causes of the disease, such as the patient's diet, salivary flow, and hygiene habits. Surgically treating a carious lesion without addressing these underlying biological risk factors is now viewed as a failure of the medical model. The goal is to treat the source of the infection, not just the symptom. To meet these standards, practitioners use two primary evidence-based tools: CAMBRA, Caries Management by Risk Assessment, and the ICCMS, the International Caries Classification and Management System. The ICCMS Merged Codes chart stages the caries process, mapping progression from a sound tooth in green to extensive decay in red. The top orange ICCMS practice box links this to a personalized care plan, categorizing patient risk to dictate preventative care frequency. By utilizing these frameworks to assess the disease in its earliest stages, practitioners can intervene biochemically to stop decay before physical cavitation ever occurs. When the biological balance fails, practitioners move to Domain 6.3, Clinical Treatment and Evaluation. In the modern model, the first line of defense is often a non-operative intervention. One breakthrough tool is Silver Diamine Fluoride, or SDF. It is an FDA-cleared liquid, applied directly to the tooth to painlessly arrest active decay. This split-screen animation shows the dual biochemical mechanism of SDF. On the left, silver ions act as an antimicrobial, rupturing bacterial cell membranes and disrupting DNA. On the right, high-concentration fluoride promotes the formation of fluoroapatite, creating a surface significantly more resistant to acid. A simple topical application of this liquid can chemically arrest up to 81% of active lesions. It achieves disease control without the need for a surgical drill or local anesthesia. In cases where a lesion has advanced to cavitation and reached the inner dentin layer, operative treatment becomes necessary. Even at this stage, the modern standard is selective caries removal. This replaces the legacy approach of removing everything until only hard, white dentin remains. Using selective caries removal, Clinicians intentionally leave affected dentin intact to protect the dentin pulp complex and maintain the tooth's vitality. They excavate only the irreversibly infected, necrotic tissue before sealing the tooth. This represents the ultimate transition in care. The modern dental practitioner is no longer a mechanic repairing holes, but a physician of the oral environment, using risk assessment and biochemistry to preserve natural tooth structure. For more insights into the future of preventive dentistry and tooth-preserving operative care, please subscribe and share this update.